Only side effect is PR prolongation, but it is not means important side effect. Now, we have given the one anti-seizure medication, one benzodiazepine, one anti-seizure medication. Patient is sensorium is not improving. If sensorium is improving, we should do continuous EEG monitoring to see whether patient is in non-convulsive status. What to give? We should start preparing the giving anesthetics. Midazolam, evidence of ongoing seizure. But more than 2.5 per, it puts a it goes into the metabolic crisis. You will see 2. It's not equal to 2.5. It is more than 2.5. But if it is 2.5 or less, there is ictal correlate means to the means evolving either morphologically or is evolving clinical is evolving clinical, or if nothing, or we should see give this IV lorazepam, then it's we can retrospectively electroclinical seizure. So what happens if it is very low frequency, like between 1 to 2 or less than 1? So when it is more than 1 and less than 2, then it's come in ictal interictal continuum. Or ictal interictal continuum is synonymous with the possible electrographic seizure. With this patient, we have to decide whether we have to treat aggressively or not, because patients get harmed by our drugs. Anesthetic drugs, they come with the concomitant side effects also, especially respiratory depression and cardiovascular and this cardiovascular suppression. So we have to keep within 2.5 for 1 second. We call it ictal continuum. If it is more than 0.5 and less than 1, we have to see the modifiers. Plus modifiers means any superimposed fast activity or any superimposed sharp waves and any superimposed delta activity. And fluctuation, we will see what is the difference between fluctuation and evolution in next slide. And if rhythmic delta activity is there, more than 1 Hz for more than 10 seconds, we have to see whether plus modifiers are there or fluctuations are there. This is called interictal continuum. What is the difference between evolution and fluctuation? Evolution can be seen in frequency, morphology, and location. Frequency means 3 sequential change in same direction. Means frequency increasing 3 times by 0.5 Hz. For fluctuation, change is by more than 0.5 Hz, but it's not in the same direction. Sometimes it will be increasing and sometimes it will be decreasing. It's not in the same direction. Similarly, for morphology, 3 de novo morphology. For fluctuation, there will be change in morphology, but it will not be de novo. Previous morphology can be repeated. Location, 2 electrode change at least. For fluctuation, 1 electrode position change. So evolution, we definitely call it as a ictal phenomena. Fluctuation, we don't give so much weightage, but there is a chance that it can cause damage. So if fluctuation are there, it comes in the ictal interictal continuum. So ictal interictal continuum. Periodic patterns 1 to 2.5 Hz without evolution or clinical correlate. Or any patterns less than 1 Hz with plus modifier or fluctuation. We have seen modifier and fluctuation. Modifier means fast activity, rhythmic delta activity, and sharp waves. Birds more than 4 Hz but less than 10 seconds. For any meaningful, this 10 seconds is arbitrary. It has been said. If it is lasting for more than 10 seconds, then it is clinically meaningful. But if it is lasting less than 10 seconds, we call it ictal interictal continuum. In case of birds, more than 4 Hz. Birds have means you can see more than 2.5, but you see less than 10 seconds. And what we should do in that situation? We should decide clinical care. What is electropharmacological care? Means patient is having seizure, patient is in altered sensorium. and patient is having some EEG changes like periodic discharge. So how we will know that these periodic discharges are causing burden to the brain, whether they are cause or whether they are effect. If they are causing means whether it is a cause, then means we have to treat it. Means it is a manifestation of dying brain. So we did not treat everything in EEG. What is electroparakinesis? If patient situation is explained by the other laboratory workup, imaging, toxicology study, if it is explainable, like a patient of acute renal failure comes with DTCS and subsequent NCS and periodic electrolyte discharges. So whether to treat that periodic electrolyte discharges or not. And patient is having some tumor or some SDH, and we are getting periodic electrolyte discharges, some midline shift is also there. So patient imaging and this laboratory workup, they are sufficient enough to explain the patient current underlying situation. So that EEG is just an EP phenomena. We should not treat that EEG. Leave it. No need to treat. Patient is going to harm by our treatment. Then in refractory status epilepticus, how to choose this among the midazolam, propofol, thiopental and ketamine. So there are some advantages and disadvantages. Midazolam we frequently use, we also use single bolus, short half-life, and is tachyphylaxis. So do constantly increase, but that will come at the cost. It will cause it is a muscle relaxant and it will cause the vasosuppression. So after 24 to 48 hours, midazolam is no longer very effective. So you have to stop it and start another drug. So whether we choose midazolam or propofol. Propofol, very rapid action. We will give propofol and we will see the EEG changes immediately. It is a GABAergic drug. Main risk with the propofol, why we fear that the propofol is the propofol infusion syndrome. It's not like that it's uncommon. It has been found, this incidence is 38%. So there are some risk factors with children. Young children, we avoid it. How to means patient will be sedated on ventilator, difficult to find this propofol infusion syndrome early diagnosis. Means patient will be having metabolic acidosis, hypertriglyceridemia, low blood pressure, rhabdomyolysis, AKI, and it is very fatal. So you want to avoid it, propofol infusion syndrome. When it happens, means young children, and risk increases when you are using catecholamines. Patient is on steroids, ketogenic. So latter part of status epilepticus, when your patient is on vasopressor, we have started immunosuppressive therapy. Some would like to give ketogenic diet also. In that situation, propofol is not a good drug. Always we should choose as a upfront, first choice. So either we give propofol or give a midazolam. So it's depend. I mean, to which drug you are comfortable, midazolam or propofol. Then comes the thiopental. Good drug, very effective, strong anti-epileptic action. Problem is that zero order kinetics. Dose will increase, drug will start getting accumulated. Means removal rate will not increase in proportion to the increasing dose. It will start getting accumulated and long half-life, long recovery time. So patient will have hypotension, cardiorespiratory depression. So this is a fearful situation which we all want to avoid. Now comes to the ketamine. Ketamine is, it was earlier not used upfront because of theoretical risk of this neurotoxicity. Means it was found that it decreases Purkinje cell level, Purkinje cells in the cerebellum, and posterior cingulate pyramidal cells injury it causes because of the excitotoxic. Means it's NMDA. All three are on the GABA. Ketamine is in the NMDA. So in state 2 mechanism, GABA decreases and glutamate comes up. So if you are using GABA with this targeting NMDA, so we are covering both the pathophysiology of the status epilepticus. So it seems a theoretical synergistic side effect, and beauty is that ketamine that it's not a cardiodepressant. So we can combine with this midazolam either together or midazolam for ketamine. So those at least midazolam, I would like that everyone should go with the dose. It comes 1 milligram per ml. Loading is 0.2 milligram per kg over 2 minutes. Maximum you can give 10 mg at a time. So if someone is 80 kg, then 10 mg only you can give. And, start infusion. So all anesthetics, there are 4 things. We should give loading, we should start infusion, we should see whether we are getting our targets achieved clinically or in EEG or not. According to that, we have to give bolus and subsequently infusion of titration also. So we have to titrate to achieve our goal. So start infusion is 0.1 milligram per kg per hour. Wait for 5 minutes. We see that the seizures are there or not. If it is there, we can give bolus. We can give bolus maximum of 2 milligram per kg. Loading dose is 0.2 and maximum bolus is 2 milligram per kg. This 0.2 means 10 times bolus we can give for midazolam. And simultaneously with each bolus we increase the dose of the midazolam. And we increase by 0.05 milligram per kg per hour. So with midazolam we see clinically seizure is stopped or not. Electrographic seizures are there or not. Accordingly, we increase. Maximum dose is 2 to 3 milligram per kg. Means people have used up to 1 to 120 milligram. And anesthetists will be always fearful how can give so much dose. Personally, I have given 50 milligram per hour, 50 ml per hour in a patient of the CKD having convulsive status. Then see, we have given the midazolam, and we have suppose we have 2 conditions will happen. We have achieved our target and we have not achieved our target. Suppose we have achieved our target, then we have to maintain it for 24 hours, and if symptoms are controlled, then we should start weaning. Even if symptoms are not controlled, we should wean because tachyphylaxis will develop and patient will be getting hypotension. So how to wean? Should not wean very rapidly. Target is there are different protocols. Target is that in first 12 hours decrease by 25% total dose. Okay. Then propofol, ketamine dose is 1 milligram. Dose is there. I will leave this slide. You can see. North and fire stimulants only. North means patient is not having any active epilepsy or any other explanation like a structural, metabolic, or toxic. We are blind. What is happening? It is thought to be presumed etiology, but not just always. Fires is a subset of NORS. They will be having fever 24 hours to 2 weeks prior. So in fires, there is a high chance that patient will be having autoimmune causes. Generally on imaging, they will be having bilateral symmetrical changes. In viral encephalitis, we get changes in MRI, but they are asymmetrical. In autoimmune cases, we get symmetrical changes. So super refractory status. We have to do cycling of anesthesia. We are using midazolam ketamine, give midazolam, then start ketamine or midazolam propofol like that. Complication management, topiramate, perampanel and cannabidiol. These are 3 oral drugs we can give. Immunosuppression. Okay, sir. And determinants are etiology, age, symptomatology, duration. Take home message is early initiation of treatment, high degree of suspicion, cycling of anesthesia, and identifying and treating etiology. Yes, sir.
So we do EEG. We get electrographic discharge and non-convulsive, only the sepsis. So sepsis related non-convulsive state.
YouTube पे है ना
ये T1 T2 बता दिया T1 T2 क्या होता है
T1 T2 का मैंने लिया पिक्चर डाल दूंगा
Seizure sepsis. Lastly, if in super refractory seizures, if you are not able to control, the role of neurosteroids will be very rampant in the coming decade. But for now, we only have the depo allopurinol. Commonly available, we have the medroxyprogesterone. So we can give 150 milligram depo provera. It's easily and very cheaply available. So even if we are not able to control within 24 hours, we can just give an intramuscular shot of 150 milligram of depo provera. That's very decade, I think, I'm sure it was not available in India, gabaxolone and prenaxolone. So, I mean, the cost was also very high. But then the basic jugaad or basic to administer medroxyzone, that will also take care of the news right now. Very well, that will also take care of the news right now. Very well presented. One thing with topiramate is that it's but not nutrient from this receptors. So this topiramate component also we can add simultaneously. We use to load with parallel. So we started 8 milligram parallel loading, and we used to taper every weekly. That is also an approach. In status, we can go up to taper every weekly. That is also an approach. In status, we can go up to much higher doses. Generally, we give 8 routine also, but we can give 24, 32, like these are few oral drugs which you can try in the per distance.
For lunch. So post lunch, we'll be starting with the